Good evening. Welcome to the New York Academy of Medicine. I'm Robert Anderson, the Senior Vice President for Academic Affairs at the Academy, and we're pleased that you elected to join us this evening. Tonight, we have the privilege of bestowing the Edwin Gibbs Memorial Lectureship and Award. And before I do that, I'd like to express sincere appreciation to Alan Weinstein for his leadership and for the selection committee depicted on this slide that worked well to determine this year's award winner. And just to put the award in perspective, these are the last 7 winners of the Gibbs Award, and you can see that this year's winner is in excellent company. Tonight, we are privileged to hear from, learn from, and honor a major contemporary individual in American nephrology. To provide an introduction, we have Dr. Bohr, Chair and Professor of Medicine at Dr. Freidman's parent institution and the nominator of Dr. Freidman for this award. Dr. Bohr?
Thank you very much, Dr. Anderson. It's really an honor and a pleasure to introduce Eli Friedman tonight. Eli is a distinguished teaching professor at State University of New York, Downstate Medical Center, Emeritus Chief of Downstate's Nephrology Division, and current Deputy Chairman of the Department of Medicine. I came to Downstate 2 years ago after 30 years at Cornell. During much of the time that I worked at Cornell, I was working for John Lara, who many of you know. John told me that the finest nephrologist in the country was Eli Friedman, and then I came to Downstate and found that the said Eli's office was just around the corner from mine, and that he arrives at work at 7 a.m. sharp every day, and that if I get into his office early before he gets really busy, I can capture at least 15 minutes of wisdom every morning, and that's usually what I try to do. I need to tell you that when I suggested to Eli that I wanted to nominate him for this award, about which I was informed by the then chairman of the Department of Urology, he said, "That's very kind, but of course it won't be successful. The Gibbs Award only goes to people who have made a real contribution." So I looked at him and I said, "Eli, you're out of your mind." However, given his censure, my job over the next couple of minutes will be to tell anyone who doesn't already know that Eli Friedman has made a real contribution. Though he didn't invent hemodialysis, Eli was centrally involved in refining dialysis techniques from the earliest times. By confirming clinically that plastic arteriovenous shunts developed by Scribner could permit repetitive hemodialysis without the need for surgical entry for each session, he helped make dialysis widely applicable. By developing the portable so-called suitcase dialyzer, he also enabled afflicted patients to travel and to live relatively normal lifestyles. Eli launched the first federally funded dialysis program. He did that at Kings County Hospital Center at Downstate in 1964. Before that extraordinary development, patients with chronic renal failure distant from Scribner's initial Seattle facility faced inexorable and imminent death. Since then, more than 1 million Americans have had their lives prolonged by dialysis. To prepare for these contributions, which were not his only contributions, Eli first graduated from Brooklyn College, and then in 1957 from Downstate. He was accepted as an intern at the Peter Brent Brigham Hospital in Boston, was assigned to Dr. John P. Merrill's newly established artificial kidney service for his initial rotation, and became immersed in the first scientific documentation of dialysis in humans. Directly after internship, Merrill asked Friedman to become his 2-year fellow from 1958 to 1960. Guided by Merrill, Eli explored several issues related to transplant immunology. During Friedman's fellowship, Merrill applied total body radiation to blunt kidney rejection, which extended successful human kidney transplantation, which had already begun, from identical twins to fraternal twins, and Eli was a co-author of the New England Journal report of this really important development. After a senior residency at Harvard and time as an epidemic intelligence officer at the CDC, Eli returned to Downstate in July of 1963, and within a week of his arrival, he performed the institution's first acute hemodialysis. To do this, he used a discarded dialysis machine that had been purchased for experimenting on dogs so they could undergo transplants. The following year, with the United States Public Health Service grant of $187,000, awarded to him to test the hypothesis that death in chronic kidney failure might be delayed by dialysis, he established the Downstate Hemodialysis Program and appointed its first fellow. That first fellow was Dr. Gerald E. Thompson, who is now the Lambert Professor of Medicine at Columbia and Vice President of Columbia, and is sitting here in the audience. So time does move on. Small world. Eli's clinic quickly became the model for dialysis centers around the country, and consequently Downstate assumed a leadership role in the world of artificial organs, with Freidman serving as president of the newly formed New York Society of Nephrology, the American Society for Artificial Internal Organs, the International Society for Artificial Organs, and other organizations. Altering and modifying techniques along the way and adding a renal transplantation program that quickly became the leader for this kind of procedure in this particular region. In effect, Eli and his team invented clinical nephrology as they progressed. Strategy in Renal Failure, the tactical guide Freidman wrote in 1978, remains a standard text in this field. Eli has authored hundreds of articles and textbook chapters, has been editor of several journals. He serves on numerous national and international boards and committees, including those of the NIH and the FDA, is regularly named on top doctors' lists, locally and nationally, and has received numerous awards and other recognitions, including the 2002 James W. Haviland Award from Northwest Kidney Centers, the 2005 Lifetime Achievement Award from the International Society for Hemodialysis, and the 2010 Barney Clark Award from the American Society for Artificial Internal Organs, as well as 5 honorary degrees from universities around the world and all kinds of other stuff. I think, Eli, that it is obvious that you have made a real contribution. So please come up and tell us about what you do.
Dr. Bora, your kind words are warmly appreciated, and I would like to thank the New York Academy. I would like to thank Dr. Anderson and all of the other notables who have kindly come this evening, with a special recognition of President John LaRosa of the Downstate Medical Center. Thank you. This evening, we're going to talk about a disease in which I will stress 3 points. The first is that diabetes and its renal complications are pandemic. Now, to illustrate that with this audience, just before I give you some statistics, could I ask those of you with a diabetic member of your family to please raise your hand? Please look around the room, and you'll see what is a pandemic. Thank you. The disease diabetes was first described by the Greeks, and the word diabetes means siphon, or to pass through, 2 different interpretations. In 1675, Thomas Willis was able to add the second part of its name, mellitus, to call it a specific disorder, which was described as uniformly fatal. Mellitus means sweet, and it was observed that flies collected on about the urine of a person with the disease who was dying and expressing polyuria. The understanding of the disease was made possible by 2 major contributions. Oskar Minkowski was a Russian Jew who feared for his family and himself because of the Tsar's anti-Semitism and left Russia to go to Germany, and there he thought it would be safer. And in Germany, he decided to attempt to test whether the pancreas, which was suspected of being responsible for diabetes, really was, by removing it in dogs who developed the disorder diabetes. That observation stimulated and this is a postage stamp that honored the 100th anniversary of Minkowski's, and that's an old urine test, the failing test for glucose in the urine, but that honored the observation that diabetes could be produced by removing the pancreas. And then a Toronto orthopedic surgeon, before there were specialties, had the idea that if he ligated the pancreatic duct of a dog and kept the dogs alive until there was degeneration of many of the cells so that the islets of Langerhans, which were thought to be related to diabetes, would remain, he might be able to isolate the secretion that caused the diabetes not to occur and could treat the diabetes. And this is his notebook page now in the Banting Museum in Toronto. In 1921, Frederick Banting, aided by his medical student co-worker, Charles H. Best, took the pancreas out of dogs, produced diabetes, and then treated the diabetes by this extract which he made from the pancreas of dogs that had had the ducts which put out the enzymes from the pancreas tied off. In other words, this dog is alive without a pancreas because of injections of this pancreas extract. Banting first called it isletin and was told it's too complicated, changed it to insulin. 1 year later, the first child with type 1 diabetes, as we call it today, uniformly fatal, was injected with isletin insulin and was kept alive. And a year after that, the Nobel Prize was awarded to Banting and MacLeod, his co-worker and chair, and insulin became available commercially very rapidly. This whole history, which is rather compelling and exciting, was recounted again in the New York Times a week ago in their science section, and they called this the first miracle drug. And the entire laboratory of Banting is now a museum. What we mean when we use the term diabetes today is a condition that has been defined by the American Diabetes Association, ADA, in their journal Diabetes Care. And there are 3 tests that can be used. Any one of them is sufficient, but generally all 3 are applied. One is the hemoglobin A1C. That's a change in hemoglobin that's been chemically affected by high blood sugar values. The normal level is up to about 5.5% of all hemoglobin. If it's higher than 6.5, it suggests diabetes. A fasting blood sugar, or a sugar 2 hours after you've eaten or had an injection of glucose, can be used also to define what is diabetes. And using this criterion in the United States, we've had the slow and now spiking curve of diabetes incidence. The percentage of the US population with diabetes is now estimated to be 13%. The cost of diabetes is now thought to have passed $200 billion a year. Now, even in our Obama budget days, that's still an impressive number. There are more than 1,700,000, probably 2 million new cases a year. It's the biggest cause of blindness, amputations, and sudden deaths in the United States. And that would make an epidemic. But a pandemic means more than just one localized area. And the estimate of the World Health Organization is that by 2030, we'll have 370 million people globally with diabetes. And anywhere you look, this is the International Diabetes Federation projection, anywhere you look on the globe, the incidence of diabetes is rising. It's estimated for the world that it will have gone up 72% from 2003 to 2025. Thus, reminiscent of what your grandparents can tell you about in 1918 when we had pandemic influenza and the armories throughout the Midwest were filled with beds like this, we now have pandemic diabetes, but most people are walking around with it. Though it is a pandemic reality, and some newspapers have taken it to its front page, including the Times and the Post, and it says the surge in the disease is slashing average lifespans. But though I used to think I understood what caused type 1 diabetes when I was an intern and resident and learned about it at Harvard, today the information is once again fuzzy. As put in a wonderful paper in the journal Diabetes of the American Diabetes Association, is that the genetics of type 1 diabetes is largely obscure. Type 1 diabetes is the one that you must have insulin for or you die as a child. It was treated before the Banting best discovery by starvation diets, and children would live a couple of years, getting very thin, as you saw. Type 2 diabetes is what happens to the majority of Americans, accounts for about 95% of all diabetes, and it can be treated without insulin, as we will see in many instances, but often needs insulin as a supplement for its control. The type 2 diabetes that causes 95% of all American diabetes has been first understood clearly and now once again not understood. Ralph DeFranzo gave the Banting lecture in 2009 and described the ominous octet. I won't detail you with these 8 different things that seem to contribute or explain. We don't know which is dominant, type 2 diabetes, though it is a genetic predisposition plus something else. And a special review was conducted, look at all those authors, to review every paper that tried to find the genetic basis of type 2 diabetes. And what their conclusion was in the journal Diabetes in 2010, our findings emphasize the importance of detailed physiological characterization of such loci, that means the part of the chromosome and the gene, which might influence type 2 diabetes risk. In other words, we don't know. After we've done all of this, reviewed all of these papers with all of these experts, we don't know what causes type 2 diabetes. One theory that I subscribe to and may have to change next week when it's pointed out how wrong I am is that a genetic accident occurred called the THRIFTY gene, and if you go to Google and you type in THRIFTY gene, you'll see both the positive and the negative, and a lot of people who say this is nonsense. Still, it makes sense to me, and I'll present it for this evening. And what it explains is why diabetes has come to the world's human population. The story probably began in Paleolithic times with our having feast or famine. Early humans had no method of storing calories, storing fat, storing glycogen, and when there was no food, they had no option but to die. And then, after the deaths in the famine era was so high, there was a mutation, and that mutation has a fancy name, peroxisome proliferator activator receptor gamma, PPAR gamma, which permitted the storage of glycogen and fats, so that cell rupture, apoptosis, lipid metabolism, the cells that ate other cells, glucose metabolism, the cell cycle, all were influenced by this genetic mutation. And when there was storage of glycogen and lipids, when there was no food, then the person would live. And if there was too much of the glycogen and lipids, they would exercise. But if they didn't have exercise, then obesity would occur, and if there was excess food with no exercise, then you had diabetes. That's one theory. It's still speculative, but it made sense to me because we've changed. This is a grandson at a restaurant, and he is demonstrating Western proclivity for excess food. My daughter Sarah, who is Associate Dean at Upstate Medical Center and here with us this evening, took me to the New York State Fair in 2004. And what I saw around me everywhere was the evidence of the existence of a thrifty gene. And this New York State Fair actually had an exhibit of a butter sculpture. It was a whole building in which butter was sculptured into something or other, and there were lines of people who wanted to see this. The obesity rates around the world indicate that something is happening to the human species. Now, I was troubled by Japan not having the rise in obesity from 1970 up to 2005. Why should Japan be excluded? But Japan wasn't excluded, it just wasn't reported properly. Because here's the Lancet for 2007, 23 million Japanese are obese. What? And not only that, but the Japanese government had made it a condition of employment by the government that your waist not exceed 33.5 inches for men and 35.4 inches for women. So obesity hit Japan as it did the rest of the world. Well, then, is diabetes the result of our genes or our own fault? In other words, should we blame the fat person for being fat? When you go to the aquarium and you see a walrus, do you say the walrus is fat or the walrus is a walrus? And when you look at your great-grandchildren, and when you see snapshots of them maybe 75 years from now, and they're all obese, are they obese or are they the new standard for the human race? And take a look at the genes versus lifestyle illustrated by two individuals who the older people in this room will recognize. James Fixx smoked 2 packs of cigarettes a day, was quite obese, and had a father who had a heart attack of 34. Immediately stopped smoking, started to exercise, wrote books on running, lost 60 pounds, had a heart attack at 52, and died suddenly. His father died at 42. By contrast, Winston Churchill, who saved the free world for World War II threats, drank 1/5 of alcohol, bourbon a day, paid no attention to diet, constantly was smoking cigars. It's hard to see him without a cigar, was obese and abhorred exercise. He said his exercise was lifting a paintbrush to do paintings of the landscape. Churchill lived till 90. So it's very difficult to indict the style of a person as responsible for the reality of that person. Supposing we are really evolving, which I think is true. Well, what could be the benefit? Why? And the answer comes in human life expectancy. The species everywhere, the United States, Europe, Africa, South America, wherever you look, we're living longer. That Cro-Magnon man that we're looking at had a life expectancy of 17 or 18. Romeo was 13 and Juliet was 12. So what has happened to our species? We've proliferated. The life expectancy has gone from 16 to greater than 75. It's nearly 80 in the United States. And the world population has gone from 1 to nearly 7 billion. Looking at who we are and what has happened then is that evolution has allowed us to live longer. That's good. But that in this perspective, as we've evolved, this thrifty gene, PPAR gamma, has meant that diabetes is a penalty that some of us must pay for the longer evolution of the life expectancy of the species. Now, in fairness, I've warned you that this view is not shared by many, and it can be attacked epidemiologically and otherwise. The thrifty gene impact can be seen in some populations, and it's interesting that Peter and Rosemary Grant at Princeton, who studied the finches of the Galapagos Islands, thought that you didn't need multiple generations of a species to see a change, that it could occur much more rapidly. And there are examples in our recent human experience. If you go out to Arizona, you can find that there are Pima Indian, P-I-M-A, subcultures in which 85 to 90% have diabetes. And of those 80 to 90% who have diabetes, approximately 3/4 have kidney disease that progresses to kidney failure. AAKP stands for the American Association of Kidney Patients, which is the largest patient organization in the world, and it was formed with Dr. Gerald Thompson, who you heard about, the guidance at Downstate some years ago, and it's a highly successful organization. And a good example of THRIFTY gene impact has been documented in Ethiopians who emigrated to Israel. They were studied at the time that they first arrived in Israel, and 0% had diabetes. 2 years later, 17%. 2 years after that, 34%. We have a similar experience in New York of the Maasai runners from the New York Marathon who stay illegally after the race is over, who have no diabetes when they complete their run and they're first tested, and then have as much as 30% diabetes when the food is plentiful. And when I asked two Indian physicians earlier, what country has the highest rate of diabetes in the world today, in this room, neither of them knew that it was India. Because, as I do, they probably have images of India in their mind as the place where Mahatma Gandhi, skeletal in rags, is barely able to eat enough to stay alive. But it ain't so. The biggest rate of diabetes is India, and 10% of adult Chinese now have diabetes. So the world is changing, and if you want to call it the THRIFTY gene or don't want to call it the THRIFTY gene, that can be argued. The prevention of diabetes is something that has been a great concern. If we could find a way to alter the patient's behavior, even though they had the genetic burden, could we prevent diabetes? And two things have been done in large trials. One is to use the drug metformin, and another is to modify lifestyle. The Kidney International, a major journal for kidney doctors, in a description earlier this year said, diabetic kidney disease, act now or pay later. After all, diabetic kidney disease, like epidemics of infectious disease that have long dominated public health agendas, is preventable. You can prevent it? Yeah, that's what they say. And the evidence is pretty good, as I will show you in a moment. And The Lancet, the major British medical journal, medicine might be winning the battle of glucose control, but is losing the war against diabetes. And in their editorial, they said a couple of months ago that type 2 diabetes, a largely preventable disorder, reached epidemic proportions, is a public health humiliation. Wow, that's pretty strong language. Type 2 diabetes, time to change our approach. Now, the prevention methodology that's best to use has been changing and is not clearly established. We're looking at the biggest trial by the Diabetes Prevention Program with thousands of people who have the cumulative incidence of diabetes on the vertical axis and years of treatment on the horizontal. And what you can see is that a very great reduction from the placebo group can be made by treating with lifestyle modification. What is lifestyle modification? We'll see that in a moment. Or an intermediate result with administration of metformin. After 10 years after randomization in the Diabetes Prevention Program trial, 34% in the lifestyle group and 18% in the metformin group did not develop diabetes. Wow. We'll digress for a moment and look at the kidney, which is the target organ that produces the kidney failure, which is the biggest cause of all kidney failure, and that's diabetic nephropathy. The kidneys are composed of a glomerulus and a tubule, and I'll show you that, and there's the part of the glomerulus, the mesangium, where bad chemistry takes place. We're born with 2 kidneys. About 1 in 1,000 of us is born with a single kidney. The kidneys are vital organs. That means if you remove them, the person dies. And each of these 1 million nephrons in each kidney has capillaries that filter and let the waste products go out and eventually turn into a drop of urine. The heart pumps blood to the kidneys. 25% of the cardiac output goes directly to the kidneys. And here, shown in a micro dissection of a kidney, is the capillary loop and the tubule, 1 million of them in each kidney. Note here the glomerulus, or the filtering part in the beginning of the tubule, the capillary loop. These red things are red blood cells in the capillary. And here, an electron microscopic image of diabetic kidney disease. On the left, a normal capillary loop with a mesangial cell. And here, the mesangium, the area in between the capillaries. On the right, with diabetes, the membrane has gotten thicker, and there's some sort of gunk, abnormal material, in the space that's called the mesangium. At the same time, the open blood vessel progressively becomes clogged of the kidney, so there's decreased blood supply and disorder in the glomerulus and the tubule. Here is a glomerulus that is highly afflicted with diabetic changes. First, note that the arterial going into the glomerulus is clogged up, the arterial coming out of the glomerulus is clogged up, and the glomerulus itself is clogged with stuff that sometimes forms nodules that were first described at Boston City Hospital by Kimmelstein and Wilson, the KW nodule of diabetes. The rest of the terms, and then we get back to the epidemiology, we follow the course of the diabetic patient by looking at 2 things. One, the glomerular filtration rate. The glomerulus is that filtering part of each of the 1 million nephrons in a kidney. And at first, it's supernormal, we're not sure why, and then it goes down to a terrible term, end-stage renal disease. Who wants to be the end stage of anything? And the other thing we follow is the amount of protein in the urine. Normally, there's almost none. Sometimes there's a microscopic amount, but in early diabetes, there's something called microalbuminuria, a little amount that isn't enough for the laboratory to pick it up with a usual test stick that they put into the urine. That becomes macroalbuminuria, then proteinuria, a lot of protein, and then at the end, the glomerular filtration rate goes away, disappears, no more making of urine, protein comes back down, the patient has end-stage renal disease and dies. What's happened to the onset of end-stage renal disease in the United States is fascinating. Progressively, starting in 1980, diabetes has grown to dominate all of kidney failure in the United States. Indeed, in 2009, as established by the United States Renal Data System, a major NIH, National Institutes of Health repository of information, diabetes accounted for 44% of all kidney failure in the United States. 44%. Now, there have been a lot of changing truths that have occurred as we watch diabetes from the time that Jerry Thompson and I began treating patients and to the present. The first changing truth is that type 1 is worse than type 2. That's what I taught. Type 2 was just a touch of sugar in an older person, and it wasn't so bad. But then there were a number of observations. For example, here's a mother-daughter. Both have diabetes. The type 1 diabetic daughter has organ injury after 25 years from being a little child. The mother, whose type 2 diabetes, supposedly the mild, began later, had organ injury, a heart attack, and other major changes after 5 years of diabetes. And this was studied at the Mayo Clinic in the best series to date, following a large number, 1,800 type 2 and 136 type 1. And this was a 35-year study. And look, the rate of kidney failure in type 1 and type 2 is the same. So the old teaching that type 1 was bad and type 2 was okay, wrong. The second old teaching that was wrong that I perpetrated was saying you don't have to worry about grandpa's little bit of sugar. Just, it's okay, nothing bad happens. But here's, at an extreme, someone who was 92 when diabetes first appeared with a lot of urine and soiling his pajamas, and by 94 he had end-stage renal disease, 2 years, leading one of our fellows under Dr. Thompson's tutelage, and I don't know whether Dr. Thompson knew Dr. Suresh, to study a large series of patients who got onto dialysis, and two variables were looked at. The first was the age when diabetes was diagnosed. Let's look at 60. And the second was the interval in years until the first dialysis for kidney failure. If you were 60, it took 10 years. If you were 40, it took about 20 years. In other words, the older you were, the faster it went. The exact reversal of what had been taught. Now, the second point for tonight, after the epidemiology, is understanding the pathogenesis of complications. And because of the diversity of the audience, I'm not going to get very heavy into the biochemistry, but I would point out that my initial teaching was that a number of steps happened, I didn't know what they were, with a high blood sugar causing kidney disease. And then we've had to clarify that by saying that if we change a number of things in the diabetic person's behavior and exposure of organs to injury, that maybe we can slow the course of diabetes. And so what works is controlling blood pressure, blood sugar, fats, getting exercise, having a good diet, and not being overly obese. It was in New York at Albert Einstein College of Medicine that a major step forward was made by someone who won the Banting medal later on and gave the Banting lecture, and that's Michael Brownlee, shown here. And of the 4 biochemical paths that were looked at, advanced glycosylated end products was suggested by Dr. Brownlee, working with the dean at the Rockefeller University. He was a fellow at the time. And what an amidori product is the first attachment of a glucose molecule to DNA, and then these molecules clump together and form an advanced glycosylated end product. And this AGE gunks up the works. It can be found easily, and you can do this experiment without a biochemistry laboratory. Take some glucose, put it in a test tube, a suspension. Take some albumin, put it in a test tube, and just put it in the refrigerator, nothing happens. Same suspension of human albumin, put a little glucose in, and within a week it begins to turn brown as the glucose acts with the albumin, changing it, glycosylating it. And we can see this. These are autopsy specimens of human cartilage, a part of the rib, in people who died of trauma or other disorder and were autopsied at Kings County Hospital. No diabetes involved, no metabolic disease. And look, the older they were, the browner the cartilage was. So advanced glycosylated end products occurs as a normal part of aging. Our friends in ophthalmology make the same observation. When they look at the eyes, these are healthy people without diabetes. The older they were, the browner they were. So advanced glycosylated end products occur normally with aging, but they occur in the kidney, that's a Kimmel-style Wilson nodule, and in the blood vessels with imidazolone is a chemical part of the AGE, advanced glycosylated end product, if you have a high blood sugar and if you have diabetes. And what we believe today, without going through the chemistry, is that the advanced glycosylated end product reacts with a receptor on certain cells, the lining cells of ducts, mesangial cells, cells that eat other cells, and then releases a series of factors, growth factors, all of which can affect the integrity of the blood vessels, the back of the eye, the heart, and the kidney. And so today that simple picture that I showed you is complicated by things like protein kinase C, transforming growth factor beta, and the receptor for advanced glycosylated end products, so that I have had to simplify it once again to say that in 2010, what happens in diabetes is that sugar, glucose, somehow activates advanced glycosylated end products, which somehow initiates oxidative stress, which is a way of damaging cells, organs, and the whole person and destroying a kidney. It's oxidative stress that goes on in advanced diabetic complications. What slows the complications? Well, regulate the blood sugar, control blood pressure, and then two new classes of drugs which have been almost miraculous. The advanced glycosylated end product inhibition, this is the angiotensin converting enzyme inhibitor. Angiotensin is an enzyme released that causes high blood pressure and injury. And the angiotensin receptor blocker, an angiotensin converting enzyme inhibitor and the receptor blocker do miraculous things. And they were the basis for a new era of treating diabetes. But although they made diabetic complications occur later, the blood pressure target that we wanted to have has been debated. In 2010, it is now advised that very strict blood pressure control that I strive to attain is the wrong thing to do, and that very tight blood pressure control may kill patients. Why did we start controlling blood pressure and think it had anything to do with diabetic complications? Well, there were studies like this one comparing these are Pima Indians, with diabetes and normal blood pressure, diabetes and high blood pressure for the relative death rate. High blood pressure is very bad for patients with diabetes. And so the American Diabetes Association recommended that we try and get a blood pressure of less than 130/80, systolic and diastolic numbers. And then using the angiotensin converting enzyme inhibitor, captopril, this monumental study done by Edwin Lewis showed that if you treat people for a mean of 3 years with type 1 diabetes, you reduce the amount of protein in the urine, a marker of damage, by 40%. You reduce kidney failure, end-stage renal disease, from 37% to 22%, and the death rate falls from 7% to 4% during that 3-year observation. Wow, so we now had for the first time a way of treating diabetes, but that drug had to be given 2 or 3 times a day. It was complicated, patients didn't take it, and so other drugs came along, and I won't go into the ACE and ARB combinations, but this was a kind of report that changed our thinking. Over 5 years, no patient went into end-stage renal disease or required dialysis. There was no increase in albumin excretion, nor was there an increase in creatinine, that's a chemical, a marker of kidney function, beyond 200 micromoles per liter. And then, as we were getting used to using the ACE inhibitors and the angiotensin converting enzyme receptor blockers, there was a warning flag. And that was that very strict control in the ON-Target and the ACCORD trials, in several relatively short trials, increased proteinuria and diabetes, but it was limited by serious hyperkalemia, high potassium, which could kill the patient, and that the doubling of serum creatinine was similar with the various drugs in combination and more frequent with a combination therapy than either one alone. What I'm trying to point out is that we led from being enthralled with the ACE plus the ARB to now what was called in 2009 in the Journal of the American College of Cardiology, the sudden demise of dual renin-angiotensin system blockade, or the soft science of the surrogate endpoint. And in 2010, and I asked Dr. Bora about this, and he knew about it as I did, the American College of Cardiology Journal said that dual blockade, that's the ACE plus the ARB, should not be used in hypertension, heart failure, and renal disease. So exactly what I said was the best way to treat the patient is now disadvised by the world-class experts like Dr. Bora. Wow, what should we do? And then as Appel pointed out in the New England Journal just a couple of weeks ago, in overall analysis, intensive blood pressure control had no effect on kidney disease progression. This was in patients who were not diabetic, and this was a part of a study of hypertension in black people. So what does all this mean? They had to have chronic kidney disease, but getting very strict control of blood pressure was not beneficial. Okay, so let's go back to the healthy lifestyle. What do we do there? Well, have fruits and vegetables at least 5 times a day. I wouldn't ask you in the audience to fill out a paper validating that you have fruits and vegetables each 5 times a day, that you exercise 12 times a month, that you're not overweight, and that none of you smoke, and that you had no more than half a glass of wine tonight. But that's what we face in a healthy lifestyle. The human is not always willing to do what he should do. So the walking is wonderful, but not everybody will walk. And we can see this in many arenas, that going for an exercise session may also not be the total experience that one might think. The adherence to a healthy lifestyle pattern has decreased during the last 18 years, with decreases documented in 3 of 5 healthy lifestyle habits. Wow, that's 2009. Now, chronic kidney disease is a new term for what is most commonly caused by diabetes, and it's found in 25% of, we'll see more, 25% of diabetic adults who have undiagnosed diabetes. Remember, 13% of Americans, now adults, have diabetes. A quarter of them have chronic kidney disease undiagnosed. And the National Heart and Nutrition Examination Survey of 2006 found chronic kidney disease in diagnosed diabetes in 40%, and in undiagnosed diabetes in 41.7%. So diabetes and kidney disease are strongly linked. Now, another reversal that we've had to deal with is that the changes in the kidney are not reversible. And that's what I taught. It was wrong because of 2 wonderful studies. The first was done in the University of Minnesota, where Michael Mauer's department and Fioretto doing the work did pancreas transplants to young type 1 diabetic people who didn't have kidney failure, but this is the kidney biopsy at the beginning of the study, and you can see these nodules, the Kimmel-Style-Wilson nodule. 5 years later, after getting a pancreas transplant, which made the diabetes go away, no change. 10 years later, the nodules are gone. So if you're a patient and you study your volunteers for a long series, you may see that the teaching that the histology of diabetes is not reversible is wrong. At the other extreme, in this study done by Mauro Salafu, who was in the room, the patients were given, in the transplant service, kidneys. These were 3 groups of diabetic patients. Steroid diabetes, that means they had this after being given prednisone or a different steroid. Type 1 and type 2 diabetes, and the kidneys came from non-diabetic donors. So how can a non-diabetic donor kidney develop diabetic kidney changes? The answer is that it's the environment, not the genes. Well, didn't you just say that it was the genes, not the environment? We're in trouble. And this is the evidence that we're dealing with today. And here's one more major truth that changed. The tighter the blood sugar control, the best you can do for the patient. If you get that hemoglobin A1C, that's a measure of what the sugar has been over the previous 2 to 3 months, below 6%, you're doing a service to your patient. But that's under rethinking now as the result of the ACCORD trial and the ADVANCE trial, which showed that intensified treatment and going to less than 6% did not reduce the complications, and it had a higher mortality. The same thing in the ADVANCE trial. Look here at the death rate, higher with intensive control than with standard control, though the intensive control got better blood sugar. And the same thing was just noted in a study of patients in the intensive care unit called the Nice Sugar Study. Diabetic patients in an intensive care unit. If you tried to get what was recommended by the American Diabetes Association, which is a blood sugar as close to 110 as possible, you killed patients. Let me show you the actual data from the report. Here is the survival. conventional glucose control over days in the intensive care unit when the diabetic person was in for some other reason, and intensive glucose control, lower survival. So we're left then with the teaching, and this is from the Annals of Internal Medicine, the Kidney and Internist Doctors Journal. Randomized trial evidence does not strongly support tight sugar control as more beneficial than harmful in reducing the risk of diabetic complications. And the change of target A1C from 7.5 to 7% should be withdrawn. This is an editorial from the British Medical Journal in 2009. And by 2010, increasing evidence suggests that glucose-centric, controlling blood sugar treatment might not result in better overall outcome. And the title of the editorial in The Lancet, Time to Change Our Approach. Well, it seems that all we've been doing is changing our approach. But look at these statistics from the British practitioners, general practitioners' experience. What we're seeing here is very large studies, 27,000 people with type 2 diabetes and oral drugs, 20,000 people with insulin-based drugs. And this is the mortality. As the hemoglobin A1C came down to 7.5%, the mortality fell. As it went below that, as recommended, it rose in both groups. In other words, it was dangerous to use the blood sugar recommendations of the American Diabetes Association, and that we should change. Diabetes and cardiovascular disease, is intensive control beneficial or deadly? Lessons from these trials. Okay, let's go to get a little bit of good news to put us in perspective. There are 3 major complications in diabetes other than the kidney disease. They lose legs, their joints don't work, and they don't feel things, and they go blind. A real advance, again, New York City, was Dr. Francis Lesperance introducing at Columbia University modern laser therapy with the argon laser. And so this is the back of the eye, a picture of hemorrhages and extra blood vessels. And what was found by Dr. Lesperance, this is one of his patients, is that if he put multiple laser burns, this is a laser burn, that the new blood vessel growth regressed and the patient retained their sight. And there were multiple examples of this. It was also shown that if you got the patient too late, after there was hemorrhage and scar tissue within the globe of the eye, you could penetrate the globe of the eye with a suction cutter device. This is a magnifying glass as Dr. Lesperance looks into the eye. And you could take an eye that looked like this with all this scar tissue and change it to this, restoring, that's a healthy disc and healthy blood vessels, restoring sight to a patient by the operation called vitrectomy. We've also learned, and here we can thank Dr. Bora and the people he's trained, that you can take coronary artery disease, where the blood vessel is closed in a type 1 diabetic woman, and open it, and here's another blood vessel closed, and open it. So coronary angiography is first done, and then either the clots are removed or a stent, a tube is put in, and you can restore function to people with coronary artery disease. Instead of cutting the leg off, and that can be the Charcot foot, the Charcot was first describing it, where the inability to feel stress meant that you had hemorrhage within the foot and that there were all sorts of changes. You could fix that first by trying medications. Here's a type 1 diabetic person who was to get a pancreas and a kidney transplant, and all these medicines to protect his foot, and they didn't work. But what did protect his foot and others is modern surgery, which in this case is an insertion. This is our divisional secretary, who in 2003 had a leg preserved by having at the Manhattan Hospital joints stabilized, and the fact that she didn't feel the foot did no longer threaten the foot, and she's walked to work, she's walks around work, and she's semi-functional, and she's had a kidney transplant for 18 years. To do all of this, it's necessary to have a real team. And I would like to emphasize the importance of our nurse educators who are the nephrologist, right hand and left hand and other hands, and keep this as a kidney with multiple Kimmel-Style-Wilson nodules and destroyed blood supply. Here are two of our nurse educators. One of them, Linda Cohn, is sitting in the room now and personally assists me with the most difficult management in changing lifestyle for patients, for which I am really grateful. In planning for end-stage renal disease in a patient who has diabetic kidney failure, early, you try and make an operation so they can have access. You put an artery and a vein together and make what's called a fistula. Then the veins in the arm get big, and you can do repeated needle punctures for dialysis. They should see a transplant surgeon. They should try and find out if anyone in the family would give them a kidney. And you should err on the early side of starting dialysis rather than the late side. And here the story is fascinating. The concept of death being delayed was first shown in patients who did not have diabetes because they were excluded specifically from admission by Scribner in Seattle and by us as we first began, because we were told that you can't do anything for the diabetic patient with kidney failure. And indeed, the inventor of the artificial kidney, Willem Kolff, published in the Journal of the American Medical Association the sad truth about hemodialysis in diabetic nephropathy in 1972, and the sad truth was that 78% died within 1 year on dialysis. Wow. How can it be then that today, the way that diabetic patients are treated, 76.8% are on center hemodialysis. This is two forms of peritoneal dialysis, a kidney transplant, and hemodialysis at the home. How can that be? This is the United States Renal Data System. Well, what we can note is that things are much better than Kolff said. If we look at two age groups, the young age group and the old age group, and we compare then, let's take people 25 to 29 with diabetes and kidney failure. They may have 8.1 years that they'd live for beyond kidney failure when they absolutely would die without treatment. Their normal life expectancy might be 52 years. If they got a kidney transplant, they could live without diabetes for 37 years, but if they had diabetes, they could still have 26 years. The older person has 10.8 years to live on dialysis, 3 years, about the same on if diabetic. And if they get a kidney transplant, 7.7 years and 6 years if they have diabetes. So things are getting better for the diabetic patient than Kolff described. And if we look here, the 2-year survival on dialysis is progressively improving so that diabetic patients live almost as long, this is the percentage who survive, as patients who don't have diabetes. And in general, things are getting better for diabetic people. And now the last point is the good news about diabetes. And the good news about diabetes was reported from the Center for Disease Control, it used to be called the Communicable Disease Center, in 2006. What they showed is that although the number of people in the United States between 1990 and 2002 with diabetes continued to rise, the rate at which they developed kidney failure was falling. In other words, what we were doing was working. And this observation was repeated and expanded in the American Diabetes Association Diabetes Care, saying that diabetes-related end-stage renal disease incidence has declined in all age groups, probably because of a reduction in the prevalence of end-stage renal disease risk factors, improved treatment, and other factors. We don't know what the other factors are. Look at this. From 1996 on, blacks, Hispanics, men, women, whites, young, old, all age groups, things are getting better. In other words, we are making a successful effort to contain the ravages caused by diabetes. And not only that, but if we look at the major complications we were talking about, amputation, renal failure, and stroke, they're all declining in incidence. There is more diabetes, and we're managing it well. Can the THRIFTY gene take credit for that management? Well, if you're going to blame it for something, that's at least a point to consider. So today, the front page of the New York Times can run a story, this was from 2006, that you could have type 1 diabetes for 80 years. These were two brothers, 80 years of type 1 diabetes. When Banting began, nobody lived more than a couple of months. And our own experience, Linda Cohn again, this is a woman who had type 1 diabetes at the age of 10. She's now 49, had a deceased donor kidney transplant 18 years ago, lost vision in one eye, but is still fully functional. This picture was taken in August of 2010. Another story of diabetes today. Type 1 diabetes began at age 6, renal failure at age 26, a kidney transplant at 27. This picture was taken at a celebration of his 20th anniversary of a kidney transplant at 47. And today, it's 8 years later, it's 6 years later, he's working full-time, and this creatinine level is a normal value. Ms. Cohn tried to call him because I wanted to check the facts for this story yesterday. He was out. He had better things to do with his time than be at home. So what next? What's coming for this pandemic? Well, the first thing, stem cells. My daughter was telling me how she has the audacity to tell her class, when my father went to medical school, no child lived with leukemia. And today, what do you think? She asked the class at Upstate Medical Center. What do you think is the rate of cure of diabetes, cure of childhood leukemia? 20%, 30%, 80%. Wow. Did I have that right, Sarah? Oh, thank you. 80%. So things change, and we do good things. And look at these two studies about stem cells. Journal of the American Medical Association. Type 1 diabetic patients, 23. 13 to 31, injected with autologous stem cells. The majority of patients achieved insulin independence. That means they didn't need insulin, with good sugar control for up to 4 years. And in type 2 diabetes, 7 of 10 stem cell recipients with type 2 diabetes reduced their insulin need by 75%. Wow, type 1 and type 2 and stem cells? Okay, let's summarize, because I see that they're getting a little bit nervous with the clock, and I don't want to hold you overly long. I would emphasize that you have to have an open mind, and that means that there are reversibles. Uremia was inevitable. Well, now it's preventable. You should, no you shouldn't, combine an ACE inhibitor and an ACE receptor, an angiotensin receptor blocker. The pathology cannot, it may be improvable. It's more likely in type 1 than type 2. No, the other is the way it is. Old people have minimal risk. No, they have maximal risk. Strict glucose control is best. Be careful. The best glucose control is the one that doesn't produce low blood sugar attacks, and I don't know what to advise as the optimal target hemoglobin A1C. Hemodialysis is of minimal benefit, not to those people who've been kept alive for years. And diabetes is, well, will be defeated. I had a series of slides that my secretary pointed out. I had to keep changing the date when I project the end of diabetes. And I have a major speaker coming to our university on April 21st. He's the head of the Harvard Massachusetts General Diabetes Center, and he's chosen for his topic on April 21st, 2011, the end of diabetes. So it's not just me who is optimistically off base and overly enthusiastic. I think that it is really possible that we will see the end of diabetes. End-stage renal disease is pandemic. The genetic and glycemic pathogenesis is probable. Renoprotective, that's the fancy word for slowing down the course, regimen is highly effective. The pandemic appears to be subsiding, but not in India or China. It is subsiding in the United States. And that means for people in developing nations, the probability of developing end-stage renal disease is lessening. If diabetes is treatable in 1922, pandemic in 2010, how wild is my prediction that it will be eradicated by 2025? Some of you will be around to see that and whether it's true. Thank you for your attention.
Thank you very much, Eli. We have time for a few questions. I should tell you, we do this as a tag team at Downstate every Thursday morning at Grand Rounds, so we're practiced at this kind of thing. That is, my having Eli answer questions. So if there are any from the audience, yes, Dr. Appel.
So Eli, as always, that's brilliant, and no matter how many times you hear parts of this, you learn more and more. My question for you is, in 2010, having said that we were going too low on the blood pressure, we were going too low on the hemoglobin A1C, well, what should we be aiming for? What is the goal for the hemoglobin A1C or sugar control? What is the goal for blood pressure control? And if you want to throw out ACE inhibitors, ARBs, which I'm not prepared to do for glomerular disease in young people as opposed to on target in older people, but if you want to throw out the combination, so what drugs would you use for blood pressure control in this population?
Dr. Appel, thank you. Dr. Appel is clinical professor at Columbia Physicians and Surgeons, and I would say that I am giving you advice, not an evidence-based answer, because I don't have the evidence. The first thing I would say is that I have not taken the combination of ACE plus ARB away from every one of my patients. I have some patients who have gone so spectacularly well, I think they would attempt to strangle me for taking away something that they attribute as life prolonging for them. I would worry about frequent episodes of hypoglycemia, especially in older people, and my target hemoglobin A1C is about 7.5%. If they go a little lower, fine, I won't scold them, but I don't ask them to go to the American Diabetes Association standard. The second is, what blood pressure level can the patient have who is doing very well with a pressure that may have some episodes of high level? For example, last Thursday, a week ago, Ms. Cohn and I saw an 84-year-old man who came to me in referral with type 2 diabetes, a creatinine of 3.5, and he came about 8 years ago, and we put him on the ACE inhibitor and a diuretic, and his creatinine is now 2.1. 8 years later, he is fully active. He complained that he couldn't do a complete course of golf, but he benefited from the drugs that I've learned to use. Should I stop going down in blood pressure? Well, he gets dizzy, and he finds sometimes when he gets up, he feels like he's going to fall down. So I backed off on the diuretic, and I'm accepting a blood pressure of 150 over 90, whereas previously I wanted 130 over 70 to 80. Am I right? If I give this talk next month, will you hear a different answer? Possibly. But I'm giving you the data as of now, and I can't manufacture new answers to your profound question.
Are you encouraged by the various campaigns that are taking place across the nation right now to combat issues like obesity, or are we barely scratching the surface and wasting our time?
I sometimes get a rage reaction by suggesting that obesity might be good for us. Let me give you, and I saw one very important front row laughter when I said that, but the example that I'd give you was put together by 2 large studies which showed the fatter you were when you started dialysis, with or without diabetes, the better your survival. That's incontrovertibly true. And it's been called the reverse epidemiology. So obesity can be better than non-obesity in some circumstances. In how many? I don't know. And I don't have an evidence-based answer for you. Do you want to focus your question a little more sharply?
Well, it's just that all across America we're slated to start this kick on obesity. Here at the Academy, we're focusing on it. Here in East Harlem.
45% of the children in New York are overweight. That's astonishing. It's about 30% nationally. It's astonishing. But is our weight changing? Are they going to live longer? Is it, if some of them pay the toll of dying from diabetes, but all of them as a group are progressively living longer, is what's happening bad or good? How dare I say such a thing? Is the mayor watching me when I actually don't care if we allow some children to have sugar in their Coca-Cola and they don't all have to have Diet Coke? I don't know the answer. But it's worth our reflection. And there's this wonderful series of articles called Reverse Epidemiology, where exactly what you have been taught is reversed, and the reversed is supportable by evidence.
Okay. Yes.
Dr. Freidman, could you comment on the paucity of positive clinical trials using metabolic manipulation for diabetes, your PKC inhibitors, your age inhibitors? Everything seems to work in the lab and nothing's translatable to the human situation.
Could you give an example so I understand exactly what you're talking about, please?
We had the inhibitor for the advanced glycation end product. There was this trial that we did, pimagidine, which is negative. There was a psilodexide. We have the PKC inhibitor, which works very well in rats, but which is all useless in humans. So could you tell us why is there a lack of this translatability?
No, I just don't think that it's reasonable for us to assume that a rat will behave the way a human behaves metabolically. This was learned some time ago with the aldose reductase inhibitors in rats, which prevented all complications, but in the humans they were worthless. Now, pimagidine, aminoguanidine, introduced by Anthony Cerami at the Rockefeller University, working with Michael Brownlee, the man who I showed you was his fellow and did the work with the AGEs. Pimagidine worked, and it did fine in 2 studies, but it was then found to have an unacceptable level of liver toxicity. It lowered the hemoglobin A1C. There was no question about that, and that lowered the AGE level. That was what the human data showed. There was a Japanese trial, and Dr. Appel, you were one of the centers that did the trial. Am I saying it correctly?
Well, there were a couple of problems.
But the problem wasn't that the drug didn't work, it was toxic.
It did decrease proteinuria and retinopathy significantly. It did not prevent doubling of the creatinine, which was the endpoint that they said to the FDA they went for, and that was it. The FDA said no, the study was over, and they didn't have any more money.
Okay, did you hear Dr. Appel say it decreased the retinopathy? That's pretty good. Anyhow, I don't have enough information to give you the kind of answer you'd like to have. How come there's another roboxitarin, which, am I saying that right? That's the one being studied by Tuttle, and it blocks a number of, does it block protein kinase C? Yeah, it blocks protein kinase C, and if you're a rat, it's wonderful. It protects you from all complications. The human trials have been a dud. Why is that? Because people aren't rats. I don't know.
Okay, we could go on with this all night. I was going to ask Eli if diabetes was actually a good thing, because he showed one slide that survival is improving, and another that diabetes is increasing by 30% over a few years. Maybe diabetes is what's making people live longer. Is that no? No, you don't think? No, I guess not.
What I'm saying, just so that I don't get the wrong message out, what I'm saying is that the thing that is causing us to live longer is having a penalty in some people of diabetes. That's how I view it. And that not that having diabetes is good for you, but living in a society where diabetes is caused because of a gene that allows you to store fats and glycogen is a good thing, as I see it. And they're going to come and take me away in a white jacket shortly.
Thank you. Well, with that having been said,
one more question.
Oh, sure. But we do need some time to be able to give you the medal.
No.
Yeah.
Okay. No, this question, Eli, I want you to reassure me about something, that the incidence of these bad things like nephropathy and retinopathy, all these things and amputations is going down. That is the percentage of diabetics who have them is going down. The incidence of diabetes is going up, but the definition of diabetes keeps changing. This is like, CKD. Every time I turn around, the last I heard, there are 32 million people now with CKD, chronic kidney disease in the country. It's going up like 1 million every month, because, they're changing the definition. I mean, in fact, it's scary. I mean, we'll all have it pretty soon. So the question is the true percentage of people that are developing renal disease and amputations going down, or is it that there's a bigger N now because the definition has changed and more milder people are into that group?
Dr. Appel has asked a seminal question that I'm not going to attempt to answer as the clock is counting down in seconds, because it needs to be examined statistically. A major player in our establishment of the criteria for saying that individuals have chronic kidney disease was Richard Glassick. He was at a meeting in Toronto last week that was attended by Dr. Appel and me, both going through terrible storms and having our planes delayed. But Dr. Glassick, who was former chairman of a department of medicine and is a distinguished emeritus professor at the University of California, pointed out that in his estimate, and he was the writer of the criteria, we should do away with the criteria for chronic kidney disease. They are more harmful than beneficial. They're confusing. For example, if Dr. Appel gives his sister a kidney, he immediately has a reduction of 50% of his glomerular filtration rate, 1 kidney instead of 2, and he has chronic kidney disease. So that should mean you shouldn't give a kidney to somebody, but of course it produces chronic kidney disease. That's nonsense, it's semantics, and we need better definitions. And I have 2 people about to clutch me around the throat, so I will stop.
Dr. Freidman, thank you for a terrific, provocative, thought-provoking talk, and on behalf of the New York Academy, I'm pleased to present you with this Edwin Gibbs Medal, and a substantial check is, quote, in the mail. And again, thank you so much.
Thank you.
Great talk, and very well done.